Hello, my name is Krish. Today I will be taking you through my common signs and symptoms mind map. This mind map is split into three sections, which are cognitive and perceptual, sensory, and motor impairments. Let's get started on cognitive and perceptual impairments. Cognitive impairments affect functions like memory, attention, language, and executive control, while perceptual impairments impact how sensory information is interpreted, meaning someone may see normally, but they may not make sense of what they see. Key brain areas include the frontal lobe for decision-making, parietal for spatial awareness, temporal for language and memory, occipital for vision, and subcortical structures like the limbic system and basal ganglia. Pathophysiology varies. Cortical or subcortical damage can cause issues like hemispatial neglect, where one side of space is ignored, or disconnection syndromes from white matter lesions, leading to slowed thinking or misinterpreted input. Common outcomes include aphasia, where people struggle to express or understand language, and visual agnosia, where objects are seen but are not recognized. These impairments deeply affect daily life, communication, mobility, and reduce all-round quality of life. Rehabilitation must be extremely specific and tailored to client needs, such as speech therapy for aphasia, scanning training for neglect, gait rehab for coordination issues, and compensatory strategies like labeling for visual agnosia. Let's move on to sensory impairments. Sensory impairments refer to reduced or lost ability to perceive input like touch, hearing, taste, smell, and proprioception, which is our sense of body position. These are seen in conditions like hearing or visual loss, diabetic neuropathy, vestibular dysfunction, and cerebellar damage. Sensory input is processed through a complex pathway involving the sensory organs, spinal cord, thalamus, and the somatosensory cortex in the parietal lobe. This image shows the sensory pathway. Skin detects a stimulus, sends an electrical signal through the sensory neurons in the spinal cord to the brain, where it's processed in the thalamus and the cerebral cortex. This elicits a motor command from the motor cortex, which travels down the spinal cord via the upper motor neurons and synapses with the lower motor neurons. This then activates the skeletal muscles at the neuromuscular junction to produce movements. Now, when these pathways are intact, they allow for normal sensory perception, but pathophysiological disruptions, such as peripheral nerve damage, reduce afferent input into the spinal cord. For example, in diabetic neuropathy, long-term hypoglycemia leads to axonal degeneration and demyelination, which reduces the ability of sensory signals to be transmitted. People may consequently suffer from hypoesthesia or diminished tactile perception. Similarly, if the individual has problems with proprioception, cerebellar damage is likely the cause of that, as the cerebellum integrates sensory input to fine-tune movements. Without this, coordination becomes disrupted, resulting in ataxia. These impairments greatly impact daily life. They increase falls risk, hinder communication, and reduce safety. For example, someone with poor sensation might not feel a burn or respond quickly to pain. In rehab, sensory re-education and neural stimulation help with hypoesthesia. Gait and balance training assist those with ataxia, and vestibular or visual rehab can restore orientation and independence. Ultimately, the sensory system is our foundation for movement and interaction. Treating these impairments helps restore not just sensation, but confidence, safety, and function. Let's move on to motor impairments. Coming into motor impairments, first we have is muscle tone. Muscle tone is the continuous passive tension in muscles that maintains posture and readiness, not strength, but resistance to stretch. Neurological conditions like stroke, Parkinson's, cerebral palsy, and spinal cord injury often disrupt this system. Here we see a cross-section of the spinal cord, color-coded to show two main pathways. Red areas represent motor or descending pathways, which carry commands from the brain to the muscles, and blue areas are the sensory or ascending pathways, which bring information from the body to the brain. When there's a disruption in these pathways, whether it's sensory input not reaching the brain or motor commands being misfired, we start to see motor impairments. Muscle tone impairments include hypertonia, such as spasticity or rigidity, and hypotonia, where muscles are floppy. These reflect dysfunction in the motor pathways. The motor cortex sends signals through the corticospinal tract. The basal ganglia regulates movement initiation, while the cerebellum fine-tunes tone and coordination. Sensory feedback from muscle spindles and Golgi tendon organs adjust tone in real time. In spasticity, seen in stroke or cerebral palsy, upper motor neuron lesions reduce inhibition of spinal reflexes, leading to velocity-dependent increases in tone. In contrast, rigidity in Parkinson's is not velocity-dependent and comes from dopamine imbalances in the basal ganglia. Hypertonia, often from cerebellar lesions, leads to decreased muscle readiness and floppy limbs. These tones these tone issues impact posture, mobility, and daily function, causing contractures, atrophy, balance issues, and difficulty with tasks like walking, dressing, or eating. Rehabilitation focuses on task-specific training, range of motion exercises, and strengthening the underused muscles. Managing tone is about balance, reducing excess tone while enabling functional, fluid movement. Next up, we have involuntary movements. Involuntary movements are uncontrolled muscle contractions that signal neurological dysfunction. They're unpredictable, not under voluntary control, and can be distressing for clients. Common cause includes Parkinson's, Huntington's, cerebellar disorders, and spinal cord injuries, each involving dysfunction in the basal ganglia, cerebellum, or spinal cord. The basal ganglia regulates movement and initiation and inhibition. The cerebellum fine-tunes coordination. The spinal cord transmits motor signals. When communication between these areas break down, movement becomes disorganized. For example, dopamine loss in the substantia nigra in Parkinson's leads to involuntary movements like akinesia, dyskinesia, and types of dyskinesia like chorea, dystonia, and apoptosis. Cerebellar damage leads to intention tremors, ataxia, and postural instability, while upper motor neuron lesions can cause hyperreflexia and spasms. Functionally, these impairments disrupt dressing, feeding, writing, or even sitting safely. They increase false risk and reduce independence. Rehabilitation focuses on neuromuscular re-education, motor retraining, and sensory integration to promote smoother and more controlled movements. Discovery learning helps clients explore what works best for them, like using weighted utensils to manage tremors. In essence, involuntary movements reflect deeper neural disruption. Our goal is to help rewire these systems so clients can regain purposeful functional movements and improve quality of life. Next up, we have motor weakness. Coming into motor weakness is a neurological deficit that reduces a person's ability to generate force for voluntary movement. It's not just fatigue, it affects coordination, control, and daily function. It is commonly seen in stroke, MS, and spinal cord injuries. Voluntary movement relies on loop involving the parietal lobe for planning, basal ganglia for movement initiation, brainstem for relaying the information, and spinal cord for the execution, all refined by feedback from muscle spindles and Golgi tendon organs. In pathophysiology, weakness can emerge from several sources. For example, in Parkinson's disease, a loss of dopamine within the basal ganglia disturbs the balance between movement initiation and inhibition, often leading to akinesia, where clients start to struggle to start motion. Damage to the parietal lobe, especially in the motor association areas, can result in apraxia, a disconnect between motor intention and execution, where the client knows what to do but cannot coordinate it. Where lesions occur in the brainstem, such as stroke or in multiple sclerosis, both upper and lower motor neurons may be affected, resulting in widespread weakness or paralysis, depending on severity and location. Additionally, if proprioceptive input is impaired, as in some spinal cord injuries, the brain can no longer accurately adjust force or posture, leading to uncoordinated, clumsy movements and instability. Functionally, clients may display abnormal gait patterns. A common example is foot drop due to dorsiflexor weakness or a hemiplegic gait where one side drags or circumducts in the upper limbs. Weakness often presents as reduced grip strength, difficulty with overhead tasks, or poor object manipulation. Rehab focuses on distributed part task and task-specific practice to rebuild strength in context. Ultimately, motor weakness affects far more than movement. It challenges independence and quality of life. Our final motor impairment is coordination. Coordination is the ability to perform smooth, accurate, and controlled movements by integrating sensory input with motor output. Simple tasks like walking, reaching, and manipulating objects are some examples. When disrupted, as in stroke, cerebral ataxia, or multiple sclerosis, movement becomes clumsy and unstable. The cerebellum plays a critical role in fine-tuning movement and using both feed-forward and feedback controls. It relies on input from muscle spindles and Golgi tendon organs to track limb position and force. Damage here can lead to dysmetria, ataxia, which are hallmark signs of poor coordination. Even with normal strength, movement can be erratic if the brain loses track of the body's position. Functionally, this presents as ataxic gait, poor balance, inaccurate reach, and reduced fine motor skills, impacting daily tasks and increasing falls risk. Rehabilitation focuses on motor learning using constant and variable practice, progressing from guided to discovery-based strategies, and applying learned skills in real-life contexts. Ultimately, coordination rehab isn't about effort, it's about rebuilding timing, control, and confidence. In summary, sensory, cognitive, and motor impairments can significantly impact an individual's ability to perceive, process, and respond to their environment. These disruptions, whether in detecting sensation, interrupting information, or executing movements, can reduce independence and quality of life. A strong understanding of underlying neurophysiology is essential for guiding effective and personalized rehabilitation strategies. Thank you.